Thank you. Thank you very much, and good evening. And it's a privilege to speak in front of you this evening, and also I thank you with my whole heart for taking time to come and listen to me. I consider stroke as a very, very important for a public to know the basics, and also I want to tell you how important time is in terms of saving brain. I'm sure you have read it, seen it on the television about strokes, signs and symptoms, and also probably some of you have ventured into internet, American Heart Association / American Stroke Association websites. They give very, very good information. But listening in a leisurely manner and a nice atmosphere is also a good thing. And we cannot go wrong to refresh our memory. So having said that, stroke is very, very passionate to me. I think I'm in 13 years at St. Vincent's now, and since I came in here, I've been doing stroke. Of course, I do general neurology, but stroke has been my passion. And most of you know that we are a certified primary stroke center at St. Vincent's. We've been certified in 2006, and to not only being a primary stroke center, we also try to achieve the quality that is required to maintain with the national guidelines. On that front, I'm proud to say that St. Vincent's has achieved Gold Plus Award. I just came to know yesterday that we've been awarded by the American Stroke Association as Gold Plus Award. So what it means to me is that we do, and also what it means to you is that when people come to the St. Vincent's Hospital, they receive or they get quality care which is followed and also equivalent to national guidelines. Not only that, okay, you come to the hospital, we do what we do at the hospital, but what we do at the hospital is across the nation, we are compared and we achieve that Gold Plus Award. It is not one person's job. I can tell you there is a team of people that work from EMS to emergency room to stroke floor, nursing, paramedical, medical staff. So it's a big team. Okay? And also, I want to thank the administration in supporting my efforts for care of the stroke patient. So time is brain. What is stroke? So what is stroke? Some people call it a brain attack. So the brain comes and attacks a person. So it's a brain attack. It's a cartoon. So we consider this heart attack. Heart attack is something that happens to the heart. Everybody knows heart attack is because of a vascular reason. That means blood flow to the heart is impaired. That's when heart attacks happen. But many people do not know stroke is a blood vessel problem, just like heart attack. So that's why it's kind of brain attack. So to put that into perspective, all our organs are supplied by the blood supply. Ultimately, we need oxygen, but blood flow, if it is blocked for any reason, that's when the stroke happens. One can ask me, what if somebody has a cardiac arrest and the blood does not go to the brain, can stroke happen? But that is considered a different strategy or different condition. It is called hypoxic brain injury. But The difference between the hypoxic injury, where there is a whole brain is lack of oxygen or blood supply, but in stroke, it is only part of the brain, focal. So in other words, part of the brain lacks blood supply. That's when a stroke happens. Why is it important that we need to know about stroke? Because it's fairly common. The biggest risk factors for stroke, one of the biggest risk factors for stroke is age. As we age, our risk goes up. So we know American people are aging and we are living longer. So it's more important to know about stroke, how we can prevent, or if somebody has a stroke, how best we can take care of the business. So stroke is one of the leading causes. The other reason why it is important is stroke can be life-changing. Last night I was at a stroke support group. One of the ladies sitting beside me tells me, "Doctor, even though stroke happened to me, my entire family changed." That is what happens to the stroke. Because usually it leaves behind some deficit. There are some fortunate people that completely recover from stroke, but there are more unfortunate people from stroke that are left with a deficit. So to give you an example how it can impact a person's life, this is a true story. 45-year-old police officer had a so-called minor stroke, but that minor stroke affected his communication, like inability to speak well, so which is called aphasia. So this 45-year-old young stroke survivor, even though he did not have the typical stroke, that means he has a weakness on one side of the body or anything, still, because he cannot communicate, he could not return to his police officer job. So that affected him, that affected his family because he can't earn his bread. And again, because he's 45, there's going to be stress on the society. So it affects all different levels. So that's how important with the stroke is. And also, why we should be knowing this is many people who survive stroke have a deficit and can't make it home. They may have to go to an institution. So that's why it's important that we should be paying attention to stroke. So what is stroke? I already said about stroke is stroke is because of the blood vessels. So blood vessels can occlude, which is called ischemic stroke. So that is roughly about 70 or 80% of the people. Or blood vessels can rupture. So if it ruptures, typically, brain hemorrhage, people are familiar with aneurysm or a bleb on the blood vessel. That's usually 25 to 30% hemorrhagic stroke. Is there a better of the two evils? If one has to choose, probably ischemic stroke is a better of the two evils, because hemorrhagic stroke patients, 50% of the people don't make it. So in other words, 50% of the people may die from the hemorrhagic stroke, especially if the aneurysm bursts. So ischemic stroke, as we saw in the previous slide, 15 to 30% are permanently disabled. So 1/3 of the people are permanently disabled and 20% are institutionalized. So far I was talking about what is stroke. Stroke can be because of the lack of blood supply, or hemorrhagic stroke, which is bleeding of the blood vessel. Both are vascular problems. So how are we going to recognize the stroke? This is where very, very important. I think if you have to take home one message, this would be the message that you would be learning. In general, people know the term stroke, but they fail to recognize the stroke symptoms simply because stroke usually does not cause pain. The human mentality is if there is a pain, automatically we get attention. Heart attack causes chest pain. That's why people go to the ER or call 911. I mean, there is no second thinking. Once people have a stressful chest pain, automatically they call 911. No doubt. Unfortunately, for stroke, I can tell you an example. Last weekend I was on call. 49, this is true story, 49-year-old lady, 49, not 79, 49. She woke up at 1 o'clock because she was hungry, because she did not have a dinner the previous night, a good dinner. So she ate something and went back to bed. 3 o'clock, she wakes up again because she did not feel good. She wanted to go to the bathroom, but she couldn't go because she was trying to sit up. She could not sit up. So she stayed in bed. 9 o'clock, she decides to call the doctor, get medical attention. That 3 to 9, 6 hours delay coming to the emergency room. Unfortunately, she suffered a stroke, which we could not help right away. So if that same woman made a trip to the emergency room or call 911, just imagine, I'll take back 1 second. If the same woman were to have chest pain at 3 o'clock in the morning, the first thing she would have done is reach for the phone and call 911. Unfortunately, stroke doesn't cause the pain, and she did not reach for the phone. Instead, she elected to sleep. That is I consider that's one of the biggest mistakes that many people make. Anyway, so what are the stroke symptoms? So, sudden numbness. Again, this is another concept. Either heart attack or stroke, in general, I'm not saying 100%, in general, they are sudden. So usually, they're okay at one point. 6:15, they're okay. 6:16, something happens, like sudden, drop of a hat. That is very important. Could they happen slowly? Yes, but that's not common. But they are very unusual strokes. Sudden numbness or weakness of the face, arm, or leg, especially on one side of the body. So that's pretty obvious. So numbness or weakness. So complete numbness, including face, arm, and the leg, that's half the body, usually. It doesn't have to be half. It could be face and arm. Or it can be just the leg, sudden. I'm not talking about people who hurt their back and then have a weakness. That's different. Okay? Then sudden confusion, trouble speaking or understanding. So I was talking to you earlier about the police officer. He was actually on the duty with a fellow officer, and all of a sudden he could not speak. So sudden loss of speech or communication. Sudden trouble seeing in one or both eyes. This is, I'll give you a great example. So the typical, this is again, typical example is wife and husband sit down to watch television after dinner. So they're watching some show or episode. All of a sudden, one of them try to clean the glasses, thinking that there is a dirt in front of the eye, and they can't see, and they rub their eye, and they put back the glasses. Still, it becomes dark, lasts for a few seconds, and then comes back to normal. They think, oh, there may be something happened, my glasses or my vision, something, but they don't pay attention. But actually, that could be a stroke to the eye. That is a warning sign. It is called amaurosis fugax. So usually, what it means is something broke loose from carotid artery and went into the back of the eye. So it could be very transient. It could be, say, 1 minute, 5 minutes. If it, usually not 5 minutes, usually very brief, about a minute or so. So that is emerosis fugax. Sudden trouble walking, dizziness, loss of balance, or coordination. So people can be walking, all of a sudden they veer to the left, and they keep going to the left or keep going to the right, and they cannot balance themselves. I just want to warn you here. Dizziness can be a very common symptom because of the ear problems, okay? But that's not what I'm talking about. This is intense dizziness, and usually they have associated with nausea or vomiting, double vision, swallowing problems. That's serious. So when that happens, don't assume that it is inner ear. Sometimes it can be extremely difficult to differentiate between the inner ear problem and stroke symptom. Again, to err on the side of safety is better. Then, so far we did not talk about anything to do with the hemorrhagic stroke. These are all usually for the ischemic stroke. Hemorrhagic stroke, bleeding in the brain, usually causes headache. Sudden, severe headache with no known cause. Even people with migraine can tell you, doctor, this headache is terrible. This is like a blow to my head. That is what the headache usually is, and comes on suddenly. Okay? So hope we are all clear on these stroke signs and symptoms. Numbness or weakness on one side, sudden confusion or difficulty talking or speaking, understanding, loss of vision in one or both eyes, and then sudden dizziness or incoordination, loss of balance, and sudden severe headache. So we learned some stroke symptoms. So I just want to demonstrate how easily we can diagnose, or if somebody on a mall having some kind of stroke symptoms, of how we can determine easily. This can be done by any person, but obviously EMS personnel is trained on this. So one of the, it's called FAST, F-A-S-T, face, arm, speech, and time of onset. So that's the mnemonic FAST, F-A-S-T, FAST, okay? Otherwise, I can say act fast. So if you want to remember, face, arm, speech, those are the three main ones. And I will tell you why we need time of onset. Face is usually one side of the face is weaker. And one can, usually it's pretty easy. When they smile or talk, basically the face twists. So that's face. And the arm, if there is a minor, if it is a paralytic, we know they can't move. But if it is a minor weakness, what do? Basically ask them to hold the hands up, and one does not come up. So that is the arm part. Then the speech is, just ask them to say something. Because we are in Bridgeport, I just said, sky is blue in Bridgeport. Okay? So that way, if we engage them in conversation, we know sometimes what happens is if we ask a question they can't comprehend, and you ask them, what day is it today? Oh, I went to market. Something, they talk something altogether different. That means they cannot comprehend. Or even if they want to say something, sometimes they say, they stutter or stumble. So that can be a sign of communication problem. Okay? Face, arm, speech, time of onset. The reason time of onset is very important for me, for the doctor who's treating the patient, is we have a clot buster that can be given in the first few hours of onset of the stroke, not when they come to the hospital. It's very important when the time of onset of the symptoms. So according to the FDA, it is 3 hours from the time of onset, 180 minutes. Each minute counts. The faster we administer the drug, the better the outcomes. I'm going to show you some slides. But a lot of research is done because 3 hours is short, very short, especially when you're talking about, say, when a person comes to the emergency room, say, for example, just think through this problem. Say a person is at home, somebody noticed, family member noticed the person who was having a stroke, then they have to call 911. So by the time 911 comes and come to the hospital, say, for example, they live very close to the hospital, we'll just say 30 minutes. By the time they notice, call 911 and put on the gurney and brought to the emergency room, 30 minutes. In the emergency room, once they are in the ambulance, they always dispatch, they send a patch to the ER doctor, so they know they are coming, which is good. Once they come in, they have to be evaluated. There are a number of testing need to be done, make sure that they are not bleeding, they have a stroke, they don't have a heart attack, and make sure that the blood is good, there are no problems with the blood, especially if the patient has a diabetes, if they have a low blood sugar, it can cause stroke-like symptoms. So we need to check all this and do a CAT scan, then only we can administer the TPA, clot buster. So it takes 30 minutes, 40 minutes, and then neurologist has to be contacted, and if they're in the hospital, they can just walk by or run by. If it is, say, 10 o'clock at night, they need to come from their home. Usually, all this happens in the background. So that's where the time is, I shouldn't say wasted, spent. So by the time all this is done, we are into 40 or 50 minutes. Say, just imagine if a patient had come to the hospital 2 hours after the onset of stroke, we only have a 60-minute window where we can administer the TPA. Fortunately, more research was done, and we extended the time window to 4.5 hours. So it is safe to give up to 4.5 hours. And now, at St. Vincent's, we are doing research with a new drug which can be extended up to 9 hours. So that's another opportunity. Say if a person comes and they don't qualify to get the TPA or the clot buster, we can certainly consider the new drug which is in the clinical trials. So any questions so far? So we talked about what is stroke, why it is important, and then we talked about stroke symptoms, and I talked about ACT FAST, F-A-S-T, okay? Believe it or not, I've seen different types of people faking stroke symptoms. Believe it or not, it happens. So we need to be extremely careful. What things can mimic like stroke? I told you already, low blood sugar can mimic like a stroke. Then I already put there conversion disorder. For some people, that's their psychological setup, and they want a secondary gain or they want attention, they fake stroke. This happens a few times a year in the emergency room. If the person has very high blood pressure, that can mimic like a stroke. I talked about hypoglycemia, which is a low blood sugar. Young people, migraine, they can come with a paralysis on one side, but they have a headache. Usually we think, oh my God, they have a bleeding in the brain. But we do the CT scan, and then when we go back on the history, we'll be able to figure that out. People who had a seizure that they can transiently have a weakness is called Todd's palsy, T-O-D-D, Todd, first way is Todd's palsy. So it's a transient. So usually they recover from it. So we need to screen for all this before we consider the clot buster. Any questions? So this is so far, as I said, one of the important things is knowing the stroke symptoms, recognizing. If we don't recognize, we can't act fast. And also, I know for sure, if we do not know in our brain, the brain can't see it. If we don't know the knowledge, we can't see it. The brain does not see it. And I can give you thousands of examples in your own life. If you don't know that, say, for example, I'll give you a common example. You are looking for some object, some special thing, and the store may be 3 blocks from where you live, but you never notice it. But once you know the store carries it, every time you pass through, you would know, oh yeah, this is the store. I'm sure we all had the experience. Or, for example, you buy Honda Accord car, and then everything on the street looks like a Honda Accord. Because we know about Honda Accord, and then we keep noticing the same car. So if we don't know, so in other words, if we don't have the knowledge about stroke, we can't see it. So it's very important to know that. So what are the risk factors? I mean, in the press and when we talk about stroke prevention, but what I'm going to talk now is a risk reduction. Even though there are risk factors that we can minimize them or manage them, but we can never prevent a stroke simply because the biggest risk factor for stroke, I shouldn't say biggest, one of the biggest risk factors for stroke is age. So even though we control blood pressure, diabetes and stuff, as we advance in our age, we cannot change that unless you buy the video Back to the Future and watch 100 times. Maybe you can go back in the future, but we can't turn the clock backwards. So that's why I term the risk factors the risk reduction rather than a stroke prevention. If we have the technology to turn this age backwards, then we can we can think about stroke prevention. But in general speaking, stroke prevention, what I'm trying to say here is stroke prevention is risk reduction. Okay? So we cannot completely eliminate the risk to 0. Okay? We can only reduce it. Because some people tell me, why doctor, I start smoking, I take the blood pressure medicine, my blood pressure is 120/80, my cholesterol numbers is normal, still I had a stroke. But what that person did was reduce their stroke. If they were to do the same things like what they did before, that means their risk would have been a lot higher. I hope that I am very clear about the stroke risk reduction. So just to go back one slide, so it can be defined as non-modifiable, modifiable, or potentially modifiable. Non-modifiable, as you can see, age, we cannot change. Gender, in general, we cannot change the gender. Race, that cannot be changed. And family history of stroke or TIA. Why, even though we talk about family history, there are very few conditions that transmit through genetics. There is a condition called CADASIL, C-A-D-A-S-I-L. That's a genetically driven disease, but there is no cure, but it is very rare. I think in my practice, probably I've seen 1 or 2 patients, and right now I'm working up 1 patient for that condition. This is extremely rare. Usually we don't see them. So the other side of the family history is, think about it. We grow up in a family. We have our eating habits from the family. So we grow up, more or less we make somewhat similar decisions to what mommy did. So you pass it on to next generation. So with some slight modifications, do the same thing again. So family histories, those kind of things play a role. Say a person always they cook with heavy oils and stuff. They learn the tricks, they pass on to the next generation and so on. So that is one of the family histories. But genetic-wise, there are very few conditions that cause, they're not very common, or at least we do not know at this stage that genetics is a big factor. But even though I totally understand high cholesterol, hypertension, some of them are genetically driven, but still, specific to stroke, they are limited, that we know. The big ones, always high blood pressure, diabetes, high cholesterol or dyslipidemia, cigarette smoking, cardiovascular disease, carotid stenosis, atrial fibrillation. You guys know what is atrial fibrillation? Some of you probably know it's a heart condition. It's an irregular heartbeat. Dietary intake, obesity, physical inactivity. I want to tie these two together. I want to enumerate on physical inactivity. Say, for example, a person, man or a woman, even if they are within the normal range of the weight, if they don't engage in physical activity, that itself is a risk factor. So I consider myself average height and weight, but still, because I'm average height and weight, I don't have to do exercise. That's wrong. Still, I have to keep up with the exercise and activity. And then we talk about postmenopausal hormone. What I want to do is a new concept relative to the stroke, metabolic syndrome. Metabolic syndrome is nothing but, this is another thing probably you guys want to learn about this. Metabolic syndrome is I'm sure you heard it in the press and the newspapers. It is a syndrome, It is a condition that we coined the term metabolic syndrome is when 3 of the 5 following features are present. Waist circumference, 40 inches for men and 34 for women. So if they have a bigger waist, they are likely to have increased risk of stroke. Elevated triglycerides, reduced HDL. So this is the good cholesterol. Good cholesterol has to be up. Or elevated BP. So systolic greater than 110, diastolic, the bottom number, 85. Glucose greater than 100. That what it means is a normal fasting glucose is roughly about 100. So if it is elevated, so that's diabetes. So if they have combination of 3 of these, it is called metabolic syndrome. So what is the importance of metabolic syndrome? They are likely to get, they are likely to get more vascular problems like heart attack or stroke. So that is the importance of metabolic syndrome. So that's why there is a campaign, Know Your Numbers, by American Heart Association. So knowing the numbers and also acting on the information is most important. So waist circumstance. Why is waist circumstance important? Because if they have a bigger gut, it's not only the abdominal fat, it is the fat inside the belly. So around our colon, intestines, there's what we call a peritoneum. That's the membrane that covers the belly that can contain fat cells. So if they have a bigger abdominal gut, they are likely to have more fat inside as well. That is also a big risk factor. That's why abdominal gut is important. I mean, if the person is a big frame, that's a different story. But for average people, okay? That's about metabolic syndrome. So metabolic syndrome increases the risk for diabetes, cardiovascular disease, and most people with active metabolic syndrome, they tend to have poor outcome in life in general. Any questions about metabolic syndrome? Okay. I'm going to skip this. So just to switching gears a little bit, just to give you some idea what the anatomy of blood circulation. In the body, everything has to get blood supply, and the body is very organized, and everything has a name, and it has a it has a function, and it targets something and does its job. So for brain, there are four major blood vessels, 2 carotid arteries on 2 sides, right and left, because we are 2 sides, so 2 carotid arteries. And in the back, what we call is, it's not here, but there is a blood vessel that comes here. It's called a vertebral artery. So there are 2. They are slender compared to carotid arteries. So the carotid arteries go to the brain, and they supply, the right side supplies right side, left side supplies left side. But it's like a traffic circle. Inside the brain, the body is created to have a little circle. It's called circle of Willis. So if one side blocks, the blood is routed from the other side. But if it happens very suddenly, that does not compensate. But if it happens over a period of 10 years, usually that circle of Willis becomes active, and the flow is redirected from right side to the left, or left side to the right, or from the front to back, or back to front. So the body has a mechanism. It's a doctor called Dr. Willis recognized this many, many years ago, so that's the name, circle of Willis. So from the heart, this is the arch of the aorta. This is anatomy 101 for everybody. Common carotid artery and internal carotid artery, and these are the blood vessels. Here is about the circle of Willis. So this is just an example of a clot in one of the blood vessels. You see this is like a whisker. This is a CT scan of a brain who just had a stroke, and this is the clot sitting in the inside the brain. So that can cause havoc in the brain. So what that white clot can do, normally the brain should look like this color. You see, kind of grayish color. But if it looks like this color, that means that damage has been done. So that white stuff has caused stroke to that extent. So these are all just examples of different types of stroke. You can see this is normal brain, but this is abnormal brain. That is the stroke. And how does a bleeding look like? You can all see this is the bleeding in the brain. That's how it looks like. So I'm coming to, yes, sir. Huh? MC is a middle cerebral artery. That's one of the name of an artery. So in my talk, I was talking to you about the time is brain, and also the T, FAST, time of onset. Why is time of onset is important? So I'm going to come to that discussion now. Obviously, stroke has been around for years and years, and the research has been done. And we know the faster we treat, the better the outcomes. Then we have to establish some national guidelines so that we can strive for better. So these are the certain timelines. Say, for example, a stroke patient comes into the hospital. So there's previously, 20 years ago, or I shouldn't say 20, 25 years ago, probably they sat there, they did not get the attention they needed, and probably they would be seen at the end of the shift rather than at the beginning of the shift. Now, things have changed because, because of the research and the advanced science, we know stroke is treated early, we get better outcomes. So how are we going to quantify? So these are certain guidelines. If a patient comes to the emergency room, has to be seen within first 10 minutes with the stroke symptoms. Or if the patient qualifies for the, what we call the clot buster or a thrombolytic, we like to get the ball rolling by 60 minutes. By 60 minutes, if they come at 7 o'clock in the evening, by 8 o'clock, we like to give that drug. Because as I said earlier, we need things to be done before we can give the medicine. So it takes some time. So our goal is by 60 minutes, we want to start giving the medicine, because it's not only doing the testing, we have to speak to the families, and for some families have more questions than the other, and sometimes family members are not available for us, and it takes several phone calls before we can get a family member. So there are all these things happen in the emergency room. And also, so between coming and giving the drug, there are other things that we need to do. As I said, CT scan has to be done, and labs have to be drawn. So all these things need to be drawn. So that's why 60 minutes. And also, we have a program from the American Stroke Association, Target Stroke, that what it means is they encourage us to give as many patients within the first 60 minutes so that they honor the hospital which achieve that target. So it's called Target Stroke. This is just a slide. So the sooner we treat, the better the outcome. So basically this is in a graph showing the sooner we treat, the better outcome. But if we treat it here, we get the better outcome, but within the first 60 minutes, it's extremely difficult from patient coming from home to the ER. By the time they come to the emergency room, it's usually 60 minutes is passed, so we can't do that. But if a patient is already in the hospital for something else, usually for a cardiac procedure, and they have a stroke, we try to get them as soon as we can. So there are situations where patients are admitted altogether a different reason, and while they're in the hospital, they have a stroke. So in those patients, we can achieve this. But if the patient is coming from outside, it is somewhat difficult. But that's why we want to get it at least by 2 hours. If not, it is safe to give up to 4.5 hours, but if the person comes, we try to get it. If a person comes at 7, we like to give by 8, okay? This is a very, very popular topic. Can people drink alcohol for stroke prevention? Probably you know, for the American Heart Association, for the heart purposes, they say, yes, alcohol has a protective effect. But my take is, I do not endorse alcohol for stroke prevention. But if the people are drinking alcohol, they should cut down too much. What is allowed is, for non-pregnant women, 1 drink, and for a man, it is 2 drinks. How do we define a drink, which is very, very important? If it is wine, it's 4 ounces of wine, not 8 ounces. Normal glass is 8 ounces, so 8 ounces is 2 drinks. If it is liquor, 0.5 ounce. It's not 1 ounce. 1 ounce is 2 drinks. Say if people drink whiskey, it's 0.5 ounce. Okay? So that's how it is defined. I just want to make sure, because this is a very popular question that I get in the public talks. For non-drinkers, I do not endorse to start drinking for stroke prevention. Okay, I just want to be absolutely clear. Of course, there shouldn't be smoking. But again, there is evidence to say that there is some risk reduction with the alcohol. Oral contraceptives. Okay, sorry. Postmenopausal therapy. So some women ask me, can they take estrogen for stroke prevention? The stand from American Stroke Association is, for stroke prevention, they do not advocate taking postmenopausal therapy. If they are taking for something else, fine. But as far as the stroke prevention purposes, it is not advised. How about oral contraceptives? Do they increase the risk? The modern oral contraceptives are very safe. However, if they are over 35, cigarette smoking, or hypertension or diabetic, or prior history of clots, they are at a higher risk. Okay? I will show you a slide. Okay. If a woman is taking oral contraceptives and smoking, their risk is 7.2 as opposed to 2.1. Okay? This is very illustrative. So if a woman wants to take oral contraceptive, that's fine, but they shouldn't be smoking at the same time. If they do, the risk is extremely high for stroke. So we talked about stroke symptoms. We talked about fast. We talked about time is brain. And also, I touched upon some of the risk factors. And also, I talked about risk reduction. As I said, risk elimination is a concept, but it's right now I would rather talk about risk reduction. Okay? Then the alcohol and oral contraceptives, which are very popular questions that I get, so I included it in the slides. So once the stroke happens, what can be done? There are medications that we adjust apart from looking after the diabetes, high cholesterol, smoking reduction. We counsel on the lifestyle changes like exercise, weight reduction. So the buzzword is lifestyle changes or modification of their lifestyle. And then there are medications, typically blood thinners, various levels. There is aspirin-like medications which are called antiplatelet agents. Aspirin, you guys know Plavix or clopidogrel, and also there's another medicine called Agornox. Okay? So those are the three medications which are kind of on the, they have a specific purpose. They're called antiplatelet agents. People who have a carotid disease, usually they go on an antiplatelet agent. Or people who have high blood pressure or hypertension go on an antiplatelet agent. That's the term. Then we have Coumadin-like medications. Coumadin is like a heavy blood thinner. But nowadays we have 2 or 3 other newer drugs which do. If a person takes Coumadin, they need to be monitored for INR every week or every month, depending on their need. But there are newer medications which do not need monitoring. There is a Pradaxa, and there is a Xarelto, and there is a Efixaban. There are 3 drugs that are available. Again, they have their good and bad things, but these newer drugs, they do not need any monitoring. They take the pill. That's the end of the story. They don't need to go to the lab, but they have their own risks and problems. We are not going to talk about it. Just to give you an overall view about this. Who takes the Coumadin-like medication? In stroke, usually people who have atrial fibrillation, those people who have a cardiac source or atrial fibrillation, they tend to take a what you call Coumadin-like medication. Then, if people have a carotid stenosis, actually a carotid stent can be done or carotid surgery can be done. Surgery is where this vascular surgeon goes and takes the plaque out and sew it, and carotid stenting is where they go in with a catheter and put in a mesh-like stuff in the blood vessel. Is the balloon there? Okay, let me put this back. So, this is the narrowing of the blood vessel. This is coming from the heart, it's in the neck, it goes to the brain, which is called carotid artery. This is where the narrowing is, and this is the balloon there, and this is how it looks like after this. That narrowing is gone. And I have another example. So, this is a narrowed blood vessel, and this is the stent. You can see there, mesh-like thing. You see the blood vessel. So that can be done. This is all done through the groin usually. So, time is brain. Nothing short of it. So, I'm open for questions now. My time is up, so